Okay, I will pin myself. Right. Okay, is that clear? Is that clear?
Yes, sir.
All right, okay. So it's good if you all can mute yourselves. Okay, I will mute everyone. Done. Fine. Okay, right. Now, today's topic is about heart disease. So what's going to happen is now heart disease is a very broad topic, and usually heart disease is managed in conjunction with the cardiologist, with the interventional cardiologist, right? With the ICU specialist, intensivist. So it's a basically a very wide field in which we get the support of all specialties concerned to manage these patients, right? So therefore, now what you need to understand is, as MBBS students, you need to have an overview. We expect you to have an overview of the whole problem of cardiac disease in pregnancy, right? We don't expect you to be a specialist in cardiac disease, nor does anyone else expect me to be a specialist in cardiac disease, okay? So we as general obstetricians would manage these patients in conjunction with the cardiologist, and especially if necessary with the interventional cardiologist, right? And often they are sometimes they have to be managed in the ICUs as well. So therefore these patients are very complex and difficult patients to manage, right? So as students, as MBBS students, you need a general overview of cardiac disease. So what we'll do is today, I will give you a general overview of cardiac disease and some components in which we need to speak about. But next time, I think we will do 2 or 3 sessions, right? I will speak to you on 4 important topics as to how to manage them during pregnancy. After the general overview, the first one would be first is coronary disease. This coronary disease complicating pregnancy, like ischemic heart disease, right? Then that is the acute coronary problems. Then I will speak to you about valvular problems like aortics and mitral valve stenosis, as to how to manage these problems. And there's another special cardiac disease which is important, right? Which you need to know is peripartum cardiomyopathy, right? So those four important topics, I will probably take 2 next time and 2 the next time. So basically we'll do 2 more sessions on cardiac disease, okay, right? So that so today our intention, children, is to discuss or to have a general overview of cardiac disease, right? Okay. So now, what are the cardiac diseases that we need to talk about, right? Number 1, basically, there are, of course, arrhythmias, right? So there can be different, and most of the commonest arrhythmias we meet, children, are supraventricular arrhythmias, right? That is what we know. So, of course, just for knowledge, if the SVTs do not get control, we can always give things like adenosine, right, to control those arrhythmias. But usually we meet them with supraventricular arrhythmias. The other group which we have is problems with pulmonary hypertension. Okay, when there may be increased pressure in the pulmonary system, then these patients come to us and then they need to be managed. Okay, so those are the second group which we meet often with this. Then comes the aortic problems like aortic dissections. So we have dissections of the aorta, which may be acute problems, which we may need to manage. And of course, there are valvular problems like aortic stenosis, mitral valve stenosis, right, which we meet with in this field. Then, of course, we need to have an idea about ischemic heart disease, right? Myocardial infarctions or ischemic heart disease, acute coronary problems, which we meet during this period. Then there are some cases who come to us with mechanical heart valves, right? Their heart valves have been replaced due to surgery, and therefore we meet patients with mechanical heart valves, right? Often what you have to understand is if there's a patient who is coming to you pregnant with mechanical heart valves, what is our most important thing? They will need to be on anticoagulation. So there are principles that we need to adhere to all for you all to understand about mechanical or anticoagulation during pregnancy. Is that clear? And then the special group, of course, is peripartum cardiomyopathy, where there are patients whose what is peripartum cardiomyopathy? It is they go into heart failure, right? Secondary to left ventricular dysfunction. The left ventricle dysfunction, but basically the whole heart dilates, right? All four chambers dilate and they go into heart failure and they can die, right? So this is peripartum. It happens towards late pregnancy or after delivery, right? So this is the period that it happens. So these are the patients also we need to talk about. Yes, somebody raised a hand. What is the question? You have to unmute yourself, child. Okay, probably. Right? Shall I continue or do you have a question? Right. So silence means probably a question. Right. So now, what happens during pregnancy? How is the heart function? So there are certain things or what we call the physiological changes in pregnancy. You might be asked a question about the physiological changes in pregnancy, which you need to know a few basics only. Okay. And they will also come maybe in your MCQs sometimes, right, which these changes. The first thing you need to understand is the cardiac output increases by about 40%, right? The heart has to work more, okay? The second thing is the heart rate also increases slightly during pregnancy, okay? So we have a bit of slight increase in the heart rate because the heart or the blood supply needs to increase to the placenta, to the mother's brain, right? So therefore the demand increases and therefore the heart rate will slightly increase. The third thing you need to understand is that the peripheral vascular resistance and the pulmonary vascular resistance drops. Okay, so the whole systemic resistance drops and therefore it becomes easier for the heart to pump blood out. And at the same time, due to the drop, usually the blood pressures will fall slightly, right? Especially in the first and the second trimesters of pregnancy, the blood pressures will fall or go down. So if we meet a patient who is having elevated blood pressure in the first trimester, then that is not good because that is staying there despite the fact that the peripheral vascular resistance should fall and the blood pressure should fall. You understand? So we need to keep in mind that normally we will get 100 by 70, sometimes 95 by 60, you know, the blood pressures will fall during the initial stages of pregnancy, right? Then You can have extrasystoles, right? You can have ventricular, you can have atrial, you can have extrasystoles during the pregnancy. And there may be slightly tachyarrhythmias, right? And there can also be, if you listen to the heart, you can hear sometimes ejection systolic murmurs, right? Because of the hyperdynamic circulation. So these are the general changes which you need to understand that can occur during pregnancy. Is that clear? So in short, if you look at that, peripheral resistance falls, pulmonary resistance falls, cardiac output increased by 40%, right? Then what it is, you can hear ejection systolic murmurs. You can see in the ECG, if you do, you can see extrasystoles, right? You might see different systolic, tachya, sometimes arrhythmias, right? These are sometimes normal during pregnancy, okay? So these are the ones that you need to be aware of. Right? Next, what are the ECG changes? Sometimes there are ECG changes during pregnancy, okay? Number one is, yes, you can get extrasystoles, right? You can see sometimes extrasystoles in the ECG, which is normal, okay? The QRS axis can shift slightly to the left, which you all know about, okay? Then you can have sinus tachycardias, which may be normal in pregnancy. There can be T inversions, which you can find in the lead 3. So you can find sometimes T inversions in lead 3, okay? And then there can be a small Q wave also appearing in the ECGs. So, and then there can be ST segment depression and T inversions in the lateral or the inferior leads. So those are the general normal ECG changes that you can find during pregnancy. Do you understand? Right? So therefore, these may be normal. So remember again, I will. So one thing is you can have systolic, sinus tachycardias, right? You can have deviation of the QRS axis to the left. You can have ST segment depression and T inversion in the inferior and the lateral leads, right? You can see an appearance of a Q wave, right? And of course, extrasystoles, which you can see, right? Then, so those are the things which you will notice during the when you do a ECG during pregnancy, which are not. Is that clear? Any questions there? So these are very straightforward stuff which we all should be knowing, right? Which so we will move on. Okay, are we clear up to now? Right. The next thing we need to talk about is what are the important things in heart disease that determines the outcome. What are the things that we need to really think about and worry about? And what are the problems with heart disease that can talk about or that can tell us about the prognosis? If you look at the whole thing, right, there are about 4 things that will show us about the prognosis. Okay. The first one is whether there is cyanosis. Right? I mean, not the first one, but one of the 4. Okay. Whether there is cyanosis. What does that say? There is hypoxemia. So probably there will be cyanosis because the heart is not functioning well. There is hypoxia and therefore cyanosis. So if the patient is cyanotic, the prognosis or we most probably will have problems. That is number 1. The second thing is the functional class, right? Normally, roughly, sorry, one moment. Okay, fine. So let's go back. Now, what are the factors that determines the prognosis? Mainly, if you ask that question, please remember there are 4 interesting factors or 4 factors that you need to talk about. Number one is the functional class, right? Now, what do we talk about? So it's a very interesting clinical functional sort of classification, which has been called what? The New York Heart Association functional class classification, in which NHYA. Okay, so and it divides the patient into 4 categories: 1, 2, 3, and 4. Number one is, say if there's a patient with heart disease, right? Number one is she can go about her ordinary work, right, without any limitations, right, with no limitations at all. So although she has the disease and we have diagnosed it, but she can go about her day-to-day activities without a problem. Okay. Functional class 2 is a patient who has mild symptoms. What is the main symptom that we consider is dyspnea, right? Who has mild symptoms when she goes about her ordinary work, right? So mildly symptomatic, right? And with little limitation. There are small limitations to her normal day-to-day activities. Functional class 3 is she has major limitations. Major limitations when she even tries to work even less than what she ordinarily does, right? So that is what, so she has major limitations in trying to work. However, at rest, she's fine. When she's resting, there are no symptoms. But when she tries to do her things, she has major limitations to her problem, right? And of course, functional class 4 is what, children? Is that the symptoms, especially dyspnea, is there even at rest. That is functional class 4, right? So it's a simple classification. I'm sure you all know that. So this is one of the major prognostic factors, or one of the major factors which you need to, what is this, think about. The second factor is the presence of cyanosis, which we spoke about, right? Then the third one is whether there is pulmonary hypertension, right? So if the patient is having pulmonary hypertension, then she can decompensate quickly, she can get into arrhythmia, she can have, very quickly she can decompensate, and she, the outcome may not be very good, right? So those are that is one thing you need to consider as the third factor. And the fourth factor is how significantly does the lesion that she has changes her hemodynamic capabilities. How does this affect the hemodynamics of the heart and the circulation, the lesion, right? So therefore, these are the 4 factors which you need to consider when you're talking about the prognosis of woman. Do you understand? So if the patient is cyanotic, if she has pulmonary hypertension, right? And if she is a New York Heart classification, functional class 3 or 4, right? And the lesion is contributing to all the problems like mitral stenosis, tight mitral stenosis, and all that, then you are looking at a problem. You all understand, right? So therefore, these are the factors that contribute towards this problem. Okay, is that clear? So this is something that generally you need to understand when you are looking at a patient with heart disease. Clear? Right. Next is, what we have to understand is, when you are talking about heart disease, is what are the general things or the types of heart disease we will encounter. So normally, generally the classification will divide into 2. Clear? What are these? Acquired and congenital. Okay. So acquired are what? Acquired are the ones the woman can have, say, idiopathic pulmonary hypertension. Okay, those may be. Then there can be aortic coarctation, right? Aortic valvular disease, right? Wait. The acquired ones are what? let's go to the congenital, the ones that they are born with, right? These are what? They can have atrial septal defects, okay? They can have VSDs, right? Then they can have different types of heart lesions, right? Then there may be aortic problems, right? Congenital. Remember, if a woman has aortic conditions, right? Congenital aortic problems, the baby also has a risk of having congenital aortic or heart problems. And therefore, automatically remember, if the woman is having an aortic valvular problem, that baby needs to be screened in utero, inside the womb, right, for congenital heart disease itself. So the best time to do a echo of the fetus is between 22 and 24 weeks. That is the best time the fetal echo should be done. So therefore, in Sri Lanka, there are specialists who are doing fetal echoes. So normally we refer to those specialists to do a fetal echo. In a woman who is having congenital aortic valvular lesions, we normally refer to these specialists to do a fetal cardio echogram, right? Echocardiogram between 22 and 24 weeks, right? Is that clear? One moment. Yeah, okay. Yeah, sure. Okay. Right, sorry. We were talking about the classification, right? So first of all, I spoke about the congenital heart disease, which is ASD, VSD, coarctations of aorta, right? Different kinds of aortic valvular disease, right? These are the congenital ones, okay? The acquired ones that comes later, what are these? In our country, most of it is rheumatic heart disease, right? Rheumatic heart disease can cause different problems. The other one is what? We can have sometimes IHDs, that is ischemic heart disease, which can cause problems, right? Then different kinds of problems like scleroderma, connective tissue diseases, sickle cell anemia, all these can cause heart lesions and thrombotic events, right? So these are the acquired ones that happens during their lifetime that we need to talk about, right? There can be infective causes like infective endocarditis. All these can cause problems in the heart, right? So these are the ones generally which we have to understand. There are congenital heart disease and acquired heart disease. Is that clear, children? All right. Okay. So now this is the general overview, right? Of course, look at the classification, right? And fill in the gaps for yourselves, right? But these are the general things that you need to understand about heart disease in general. Is that clear? Right? This is a general overview, right? Because for MBBS, we need to have a general overview of the whole problem, right? So now let's go one by one, and I will tell you a bit, give you a general overview of each of these problems, okay? Let's take, first of all, let's take, valvular mechanical heart valves, right? Because we do get patients who we sometimes get them with when the heart valves have been replaced with mechanical heart valves, right? These patients, this usually these valves function very well. There are new ones, specific, very modern ones, which are very good, right? And they function very well, and the patient is often asymptomatic. But what is our biggest problem, children? The biggest problem with artificial heart valves is anticoagulation. They have to be on lifelong anticoagulation. So now, when they become pregnant, this poses different problems. Why? Because most of them are on warfarin anticoagulation, right? So now, generally speaking, for anticoagulation, other than mainly we have what? We have warfarin, yeah. We have low molecular weight heparins, and we have heparin. Okay, so these are the three large things. Of course, you add sometimes low dose aspirin, especially for low molecular weight heparins, but that is secondary. But the main means are warfarin, low molecular weight heparins, and heparins. Generally, what you have to understand, children, is warfarin causes problems to the baby. Okay, it generally does not cause problems to the mother, right? And heparin or low molecular weight heparins cause problems to the mother. So when a woman is on anticoagulation with warfarin, right, the problems are mainly to the baby. What are these? These are called warfarin embryopathy. So it can be toxic to the embryo, and the baby can have different congenital problems, malformations. Okay, that is called warfarin embryopathy. The baby can have bleeding inside the head, which is called intracerebral hemorrhage, right? The baby, there can be death in utero due to bleeding in the baby, right? So these ones can cause problems to the baby. So therefore, this warfarin embryopathy is mainly between 6 weeks and 12 weeks of pregnancy. So what we have to do is we have to try and avoid that sometimes. Do you understand? But for patients who are on, if you are going to put them on heparin or low molecular heparins, the biggest problem is they can have thrombosis of the valves, right? And it causes thromboembolism, right? So the risk is warfarin gives less thromboembolism and thrombotic events, okay? And so the risk is more to the baby. On the other hand, heparin gives more thrombotic events and thromboembolism, but the risk to the baby is extremely low, right? So that is what you have to understand about these two medications, right? So if you give warfarin, one of the options is to give warfarin throughout pregnancy, but at the cost of a possible embryopathy during the 6 and 12 weeks of pregnancy, right? If you give heparin throughout the pregnancy, that is also possible, heparin or low molecular heparin, you can, the risk to the baby is minimal, almost non-existent. However, the chance of a thrombotic event, right, or thromboembolism is very high. Not very high, but high. Do you understand? So therefore, management seems to, there is a, we can choose either if we have very good monitoring. We can either go with warfarin only, or we're taking the risk for the baby. We can go with heparin only, taking the risk for the mother. One of the options that have been practiced is what? You stop warfarin for this patient between 6 and 12 weeks and commence on it afterwards, where they have the greatest risk of warfarin embryopathy. Okay, and then continue warfarin during pregnancy. During that period, you switch them on to low molecular weight heparin or heparin. Is that clear? Right? If you give heparin throughout pregnancy, of course, you need to add aspirin as well, low dose aspirin to low molecular. You don't need to add aspirin to warfarin, but you need to add aspirin to low molecular weight heparins, right? Then, if the patient is on warfarin now, 10 days before delivery, you need to stop warfarin. The reason being, the warfarin needs to be flushed out of the baby's system before the baby comes out. Otherwise, the baby can have problems when it's born. So you stop it 10 days before delivery, and then you put them on low molecular weight heparins for the delivery, right? Up to the delivery. During the delivery, you omit heparin or warfarin, right? We don't keep them anticoagulated during the delivery. After delivery is over, you recommence warfarin 5 to 6 days postpartum. But you can cover the anticoagulation low molecular weight heparin in the postpartum period. Is that clear, children? So during delivery, heparin is omitted. 10 days before, if the patient is in warfarin, then 10 days before the delivery, the warfarin is stopped. And then it's recommenced 5 to 6 days postpartum. Till then, you have to continue low molecular weight heparin. Is that clear, children? So generally, what you have to understand is for the principles of anticoagulation are the ones which I just laid out for you to understand or have a general view. So to summarize again, warfarin is safe for the mother. Okay. And warfarin